Introduction. Acute tubular necrosis (ATN) stands as the most prevalent form of acute kidney injury, AKI, and is primarily caused by the ischemia of tubule cells. This essay delves into the intricacies of ATN, exploring its origins, mechanisms, and the clinical phases it manifests through. ATN is predominantly induced by decreased renal perfusion, leading to ischemic damage to the kidney tubules. Mechanisms of ATN. ATN is often a consequence of decreased renal perfusion, commonly seen in scenarios like severe blood loss, myocardial infarction (MI), and systemic hypoperfusion. Ischemic injury to the endothelial cells results in reduced nitric oxide, a vasodilator, and increased endothelin, a vasoconstrictor, production. This ischemic injury causes vasoconstriction in the damaged afferent arteriole, impeding blood flow to the glomerulus. Consequently, glomerular filtration rate (GFR) diminishes, leading to the characteristic features of ATN. Pathological features of ATN. ATN is identifiable by the presence of muddy brown casts in urine sediment, indicating sloughed tubular cells. The obstruction caused by sloughed cells in the tubular lumen further diminishes GFR. The proximal convoluted tubule and the thick ascending limb of the loop of Henle are particularly susceptible to ischemic injury in ATN. Microscopic examination reveals dilated tubules with patchy loss of epithelial cells, ruptured basement membranes, and vacuolization of epithelial cells in affected nephrons. Clinical phases of ATN. ATN progresses through distinct clinical phases. The initiation phase, occurring within approximately 36 hours of the initial insult, is marked by the absence of severe symptoms. During this phase, kidney function and urine output remain relatively normal. The subsequent maintenance phase, lasting 1 to 2 weeks after the initial insult, sees the development of AKI with severe metabolic derangements and reduced urine output. Elevated levels of blood urea nitrogen, BUN, and creatinine, oliguria, and fluid overload are characteristic of this phase. Recovery and nephrotoxic ATN. The recovery phase, transpiring 1 to 2 weeks after the initial insult, witnesses tubular reepithelialization and profound diuresis, with urine output increasing up to 3 to 5 L/day. However, this phase can bring about electrolyte abnormalities such as hypokalemia, hyponatremia, hypocalcemia, and hypomagnesemia. Nephrotoxic ATN is a distinct form of ATN induced by external factors. Aminoglycosides, damaged muscle due to crush injuries or rhabdomyolysis, and intravenous contrast agents are common causes of nephrotoxic ATN. Damaged muscle releases nephrotoxic heme pigments into the bloodstream, subsequently leading to ATN. Conclusion. Acute tubular necrosis, primarily caused by ischemic injury to tubular cells, manifests through various clinical phases, each characterized by specific symptoms and features. Understanding the mechanisms and clinical progression of ATN is vital for accurate diagnosis and effective management, ensuring better outcomes for patients affected by this prevalent form of acute kidney injury.